for this patient. Okay. So the first thing we have to do is how much alveoloplasty is needed. Definitely these two teeth are supra-erupted and this bone level we have to reduce. Okay. So this we have to take it as a guideline and we have to remove this bone. And anteriorly there is some canine root stump is there. We have to do a minimal alveoloplasty here. Comparatively the mental foramen are closer to the crest. There is resorption here. Maybe long-term edentulous. But the bone width looks very good. If you see the molar, premolar, even the anterior, it is very good. So we can use a wider diameter implant. Since we can use a wider diameter implant, we can choose to place only 6. Below curvature. So this is the panoramic view. So our plan is to place 4 implants in the mental foramina and 1 implant in the molar region. So see part off minute. Okay.
Part off.
So as usual, our first implant is in the first premolar and second implant in the lateral incisor. 1 implant in the molar on the right side. Okay. We will see the first premolar first. So already there is first premolar present, so we can take it as a guideline. So when you have got some teeth, they serve as a landmark for us. If there is no teeth, then we are clueless. So presence of teeth and socket, they serve as a landmark. You see the width is good, the length is good, 4.2, 14, 16 you can place. But I chose to place only 13 because the bone is very dense. Even the alveolar bone, intramedullary bone is 1200, 1500. The difficulty we may face is the insertion of implant will be difficult. It may get stuck in the middle. So we should drill up to the tip, up to the entire depth. We may have to use the wider drills. So even though long implants can be placed, it is better to place only short implants because the width is good, the bone quality is good, the stability which you will achieve is will be good. This is the lateral incisor. Here also if you see, the entire intramedullary is very much cortical, 1200, 1500 is very much, it's too much. It is a classic D1 bone. So what we can do is we can reduce the diameter of the implant we are placing, 3.75 into 16 you can place, or 13, whatever it is. Or if you can drill with wider drills, you can place 4.2. Okay. So the molar implant we will see. See the molar implant. Exactly where you remove the root stump and you can place. There is myloid ridges coming here. The nerve is very much far away. This must be the nerve. From the nerve to the myloid ridge, there is good amount of width is there. So start from the middle of the alveolar bone. Stay closer to the lingual plate. Keep your finger on the lingual aspect. 4.1 into 13. Up to 13 it shows. But you have to determine the exact length during the drilling. It may vary. Okay. So always keep abutment so that you will understand. So whenever you are placing molar implant in this kind of situation, make sure it is in the distal root of molar. Otherwise you will get cantilever. Okay, then you may have prosthetic breakage in the cantilever area. So here this root stump will serve as a landmark for us. So exactly where you remove this root stump, you can choose to place the last molar implant. Now we are planning for the left side. 1 molar, 1 first premolar and 1 lateral incisor. We will see the lateral incisor. Here also the bone is very dense, similar to the right side. So the main challenge will be the drilling and implant placement. Stability is not an issue. If you are not careful, the implant may get stuck in between or the abutment may break. Okay. Since the bone is very cortical and excellent and dense and good, only 6 implant is enough. Even you don't need to place longer implant, there is no need. Here also, just in front of the mental foramen, we are going to do flap. We will expose the mental foramen and we will drill just in front of the mental foramen. Anyway, we are going to do alveoloplasty, we are going to do open the flap. At the same time, you can open and see the, expose and see the mental foramen. Here, this is the maybe in the first molar distal root region. The anatomy is very much favorable. Whenever you see this kind of undercut, this is favorable. Either you can place implant straightforward, no lingual cortical engagement, but the length available is only 8 mm, right? So better you can choose lingual cortical engagement, you will get the cortical bonus 1400, 1300, slight tilt towards the lingual aspect, 4.2 into 10 or 4.28, whatever it is. Okay. So it is a comparatively easy situation, but the drilling will be more, and the implant insertion should do it very slow, otherwise we may end up in breaking the implant, breaking the implant. Okay, we'll start.